I want to talk first about outcomes in urea cycle disorders because I think that's something we are understanding more and more about these disorders. There was a very early publication by Mark Batcha, I think in 1984, that looked at that there is a correlation between the initial length of coma in urea cycle disorders, right, at first presentation, and subsequent intellectual outcome, okay? But this is a very, very crude marker, right? I mean, not all patients necessarily present with this degree of hyperammonemia to the point where they're comatose. And so subsequent work that we've been trying to do through the Urea Cycle Disorders Consortium is to better clarify sort of what the outcomes are for these children. There have been several publications that have looked at that to date. One of them that I was one of the authors on in 2012 looked at the difference between early onset proximal urea cycle disorders versus the distal urea cycle disorders. And I hope that term means something to you. Essentially what I mean by that is that proximal disorders are the early mitochondrial ones. That's NAG synthase, CPS1, and OTC. And comparing those to the more distal cycle disorders, argininosuccinic acid synthase deficiency and the lyase deficiency. And so traditionally, these disorders the distal disorders were seen perhaps as milder because the hyperammonemia may not necessarily be as severe. It is further away from where ammonia comes into the cycle, and therefore the hyperammonemia tends not to be as bad. Okay, but sort of one of the things we found in this study is that in fact that's not true when it comes to the subsequent outcome of these disorders. That some of these disorders in fact can be equally severe in terms of the intellectual outcome of these disorders. That they still have developmental quotients that are reduced. Some of this may come from the fact that we don't transplant these kids as early, but I think also there's a component now as well that for instance in ASA lyase, that the accumulation of ASA can also cause not only liver damage, but can contribute to intellectual disability in this disorder. There was also a recent publication by the European group. That group has been working on, more broadly speaking, what they are described as intoxication type disorders. So these disorders are the urea cycle disorders, but also include organic acidemias and glutaric acidemias. But they looked in the urea cycle disorders and they found as well an association between the number of episodes as well as the intellectual outcome, right? So there's a positive correlation between, now this perhaps was intuitive, but the studies needed to show that this was the case, that the more frequent the hyperammonemia, the worse the intellectual outcome. Again, may be obvious, but again, that study had to be shown. And this is from our group as well. Again, I apologize that the numbers don't come out, but essentially what it was looking at was sort of in the newborn period, what the intellectual outcome, the developmental quotients are like, and then sort of in the preschool age, and you can see obviously that all of them have some degree of developmental delays. So the point here is that the real critical component of these disorders is to prevent these hyperammonemic episodes, not surprisingly, okay? That these cause, it can contribute to intellectual delay over time. This is why certainly in North America there has been more of a push to transplant these kids, okay? And so because it can prevent obviously the recurrent hyperammonemia. It doesn't fix all of the problems, as I'll get to in a second, but that at least it is able to prevent the hyperammonemia. And using one of Marshall's words, he likes to say that's poor man's gene therapy. Effectively what you're doing is you're removing an old liver, putting a new liver, right? Ideally, we would like to, in the future, perhaps correct the metabolic defect in situ, but we don't have the ability to do that right now. So with that in mind, this is again, apologies for the small, the not very legible graphics here, but this is a very preliminary study in patients with early liver transplant. And you'll just have to trust me on this, but essentially that these are, you can see here, these are kids with Otc deficiency and CPS1 deficiency, and that they track the developmental quotient over time post-transplant, and that there was an improvement following the liver transplantation. And I will tell you anecdotally as well that these patients do better post-transplant. Obviously there's associated morbidity and mortality with these disorders, so that's something that has to be thoroughly discussed with the families, but I think in many of these kids the outcome, if the liver transplant is successful, which it is most of the time, that these, in the hands of a good surgeon, mind you, like good experienced surgeon, which I understand in Argentina you have many, so that the outcome can be very good for these kids. Currently, I'm the primary investigator of a larger study that we are trying to look at this in a little bit more detail. This is some preliminary work by my colleague Philippe Campeau. But we're trying to look at within the Urea Cycle Disorders Consortium all of the patients that we have with liver transplant and compare them or with controls also within this consortium. I didn't explain that too much, but if you're unfamiliar, within the United States there is a consortium that's funded by the National Institutes of Health, right? So it's a federally funded group consisting now of 13 different institutions within the United States, so basically all the major hospitals in the pediatric hospitals in the US, as well as a few international sites. We have sites in Toronto, Canada, Zurich, Switzerland, and then Heidelberg, Germany. And all of these sites have a particular interest in urea cycle disorders, and we are the central site in Washington, D.C. And so the largest study of these is something called the longitudinal study of urea cycle disorders. We have throughout the network 700, approaching 800 patients with urea cycle disorders. Now, some of you look impressed, some of you not, so it depends on how you view that number. Either that's a very large number, right? Or you can say, 14, whatever, 15 sites, 800 patients, that doesn't seem too many. So, but it goes to show, as we were discussing earlier, the only way to do these studies is through a large multi-site collaboration. That's what's required to
Yeah, we
do
estimate
these.
like 90 in Argentina. I don't know what you think, 90, 85 in Argentina. We almost alive.
Perhaps. I don't have.
But that's our guesstimate.
Right.
Our guesstimate.
So the estimated incidence of these is about, in total, 1 in 35,000. About half of these will be patients with OTC, right?
Yeah.
And then the next common is argininosuccinic acid lyase deficiency. Now, but I understand that there's a specific region of Argentina where there is a common mutation in the citrullinemia gene, if I'm not mistaken. Is that correct? So your numbers may differ here slightly from ours, but that's roughly sort of the makeup of even within our consortium. That's the numbers. Half of them are OTC patients, and then the rest are the other half. So once you transplant a patient, it's important to remember that you're only correcting the hepatic urea cycle, but these enzymes are expressed elsewhere in the body as well, right? So I see everybody shaking their head. They're expressed, so for instance, some other, okay, so here you can see just the different enzymes, so NAG synthase, CPS1, OTC, ASS, ASL, arginase, citrin, or the ornithine transporter. And so you can see here the liver is where all of these show the greatest expression, right? But that these top three, the proximal urea cycle disorders, are expressed as well in the intestine, and then these other two also in the kidney. So why is that important? Because this aspect, these enzymes are present in the small intestine. And the role of these in the small intestine is to export citrulline. In fact, it can consume some glutamine and generate citrulline to export through the portal circulation. The liver itself it does not modify citrulline, so citrulline passes through the liver unchanged. Okay? So then where does it go? Well, the citrulline then goes to the kidney. The kidney has these two enzymes active, and it has a little bit of arginase in order to be able to make some urea, obviously, as well. But these two are predominant, and then the kidney then makes arginine out of this. So the reason this is really important is because once you transplant the liver, you've corrected the metabolic defect in the liver, but you haven't corrected these other defects that are within this individual. Now, that's important because arginine, as you might know, is it's an amino acid, but it's a non-essential amino acid, and it's non-essential because it is made through this pathway, right? So if you have a urea cycle disorder, it becomes essential. You need to replace that, okay? Otherwise, these individuals don't have any arginine. And so you can do this in several different ways. So I think the most straightforward is in Asl deficiency again. So this is, just to orient you here, this is ammonia carbamoyl phosphate. This is the OTC enzyme with citrulline. This is the gene for citrullinemia, ASS1. And this, you make arginine or succinate, and your defect is here, right? So one way to look at this cycle, if you have a defect here, it becomes a linear pathway from arginine to arginine or succinate, right? If you have a block there. So in other words, you go from arginine straight down to arginine or succinate, right? Hopefully that makes sense. So that what happens is over time, if you do not replace arginine, then two things happen. One, you'll become deficient in arginine, but then the other two is that none of this will work. None of this pathway will work, right? So, and this is extraordinarily important because you pull in two nitrogens, one from ammonia and one from aspartate, right? So if you ask some of the older generation doctors, they will say, in this disorder, you can control hyperammonemia with arginine alone. You don't need anything else. You can give high-dose arginine and correct the hyperammonemia, right? Because you're giving arginine, which has 4 nitrogens. You get rid of urea, which is 2. And then at the end, you get rid of arginine or succinate as well, which is 4 nitrogens in it, right? So it's net excretion, and this is not recognized by kidney transporters. Therefore, it's not reabsorbed. Therefore, you are eliminating this in the urine. So this allows you to, this allows the body to get rid of sufficient nitrogen, right, through this alone. The reason why we don't necessarily do this is we found out, as I discussed before, arginine or succinate through some of the recent work by Brendan Lee's group at Baylor also is bad. It can cause liver damage, and so the preference now is moving towards a low-dose arginine with high-dose ammonia scavengers. Does that make sense? If I'm not going to, I talk a little fast, so please interrupt me if there's any questions. Okay, so in OTC deficiency, obviously, the block is here. You go from citrulline to ornithine. So therefore, in this case, it's really important in these conditions, again, when you transplant the liver, that you find a way to replenish arginine. Now, arginine, in the bowel, there's a lot of arginase. The liver has a lot of arginase. So typically, when you just give arginine, a lot of it, about half of it, is degraded even before it gets to the peripheral circulation. So that's not the best option in this disorder. It's preferable, as I mentioned, to provide citrulline. Why? Because, as mentioned, it passes through the liver unimpeded, right? It unmetabolized. So it allows you to then replenish arginine in that fashion without getting any degradation of any kind. The other reason why this is important is if you give arginine, that's essentially nitrogen. You would be nitrogen positive. You're giving 4 nitrogens, and then if you're breaking it down, then there's 2 nitrogens that kind of remain in the system. So I think that's a scenario that you want to avoid. Citrulline, on the other hand, is net neutral. Citrulline is 3 nitrogens. You bring in 1, you get rid of 2, and then you have 2 left, right? So it's net neutral in terms of the amount of nitrogens that you give, and that's why I think citrulline is a preferred choice in this disorder. So with that in mind, just again, basically, liver transplant I think is really important as a therapy in urea cycle disorders, but you can't forget to replace whatever amino acid that's generating the arginine. That make sense? Okay. I want to talk a little bit about alternative pathway medications. I understand here you're obviously familiar with the use of benzoate in these disorders. Benzoate combines with glycine to make hippuric acid, and as a result gets rid of the one nitrogen in glycine. In North America, we have a tendency to use phenylacetate. Not necessarily because it is more effective, but the impression I get is it probably is slightly more effective. Here you're combining glutamine to phenylacetyl-CoA, which is then combining to form phenylacetylglutamine. And then we have several derivatives of this that we also use phenol butyrate as well as glycerol phenol butyrate, which I'll talk about in a minute. This, interestingly, I don't know whether you guys are familiar with the story. We have time to tell a brief story about this. Mark Batshaw, who is the chief academic officer of our hospital, discovered these medications, or was the first to propose their use along with Saul Brusilo at Johns Hopkins University. But this was entirely fortuitous. In those days, what used to happen is when you used to write a grant, the NIH reviewer would come and talk to you about the science and discuss that a little bit further. So what they had talked about at the time was not even this. What they were thinking about using was he was thinking about using keto acids. And those, so basically, as you may already be familiar, that the first step in the degradation of many amino acids is a deamination step, right? It is the transfer of the amino group from whatever compound to alpha-ketoglutarate to make glutamate, okay? And so there are, essentially 5 amino acids that you can, that have that as the first step. 5 essential amino acids that have that as the first step. The branched chain amino acids, if I'm not mistaken, I think methionine, and they can happen with phenylalanine as well. So the reason this is relevant is because they had described the use of keto acids. In other words, using the keto acid. So for instance, if you take leucine as an example, if you gave 3-hydroxyisocobroic to a patient, they would naturally, right, aminate that. They would add the nitrogen back to make leucine. So it is a method, potentially, of providing an amino acid to a patient without providing the nitrogen, right? So that's a great idea. When they discussed this with the reviewer, when they discussed this with the NIH reviewer, that gentleman actually had said, you know what, if you are interested in improving nitrogen excretion, I remember this article from something like 1917 in the Journal of Biochemistry about the use of sodium benzoate and how that you can excrete hippuric acid in that fashion. And so Dr. Batshaw, who was in the 70s, a fellow at the time, ran down to the stacks of the library basement to look for this article, and he found the article that described exactly this reaction. And the article just after that described this reaction, right? So just entirely fortuitously, but really importantly changed our field in terms of this, in terms of the ammonia scavengers that we use these days. Notably, that other therapy, I think, has kind of been pushed to the side, right? So nobody at the moment has developed the keto acids, and I've always wondered whether that's worth kind of exploring in the future as a potential adjunctive therapy in these disorders. In any case, phenylacetate, again, I don't know if any of you are familiar, have tried this or smelled this or anything? No? Nobody? It's terrible. This is essentially unpalatable. You can't, the taste is just horrible, right? So if you walk into a room where a patient has infused phenylacetate, just the smell is overwhelming. So instead, they develop phenol butyrate, right, which is basically phenylacetic acid. You've just added one additional acetyl group to it, right? So you allow for one beta oxidation step, right, to make phenylacetic acid, right? And now we have something called glycerol phenol butyrate, right? Which is essentially when you take if you think about it, there's a glycerol backbone with 3 fatty acids, but you replace each of these with a phenol butyrate molecule, right? So this is glycerol phenol butyrate, right? So this is what it looks like. I highlight the glycerol backbone to make it obvious. And so this is something that is being used now. I didn't really want this to be a product advertisement, but I didn't know how else to show this to you. This is currently what we use. This is the only company that makes it currently. It's called Ravicti. It's just a clear liquid. So I thought about showing a syringe that had a clear liquid in it, but I didn't feel like that would be of any benefit. But in any case, so again, just make sure it's clear. You take glycerol phenol butyrate. There's there's an ester hydrolysis through pancreatic lipases that break that down into its fatty acid components. You beta oxidize this to make phenylacetylglutamine, right? And so there are this is a drug that has only been available in the United States for the last 4 or 5 years or thereabouts, and there's in fact still an ongoing study of this medication in young children, because the concern was that they would not have sufficient pancreatic lipases to break them down. As it turns out, that's not true. These kids do absolutely fine with this medication. But there are some advantages and disadvantages of this. So what are the advantages? One, they're tasteless and odorless. This is kind of depends on who you ask, right? So tasteless really depends on who's trying it. Some people say it tastes very oily, a little bit like varnish. Others say just like water. So it really depends. It's fairly odorless, I would say. This has been marketed with the idea that the compliance would be improved. Obviously, if you make it more palatable, that people would be able to take it. It is also in a smaller volume. There's no excipient. So for instance, our phenol butyrate tablets are 500 milligrams. So an adult patient is taking upwards of 30 tablets a day. But each tablet is 500 milligrams, but 1 milliliter has 1.1 grams of active substance. So that means that they're taking 30 milliliters a day. That's much more reasonable as a volume of drug, right? So they will take 10 milliliters, right? So like 2 tablespoons, if you will, just 3 times a day, which makes that a lot easier. There are some disadvantages to that, however. It is difficult to administer via tube. Right? So if you have a tube, it'll just get stuck in the tube, right? So it's a little bit more challenging. One of the tricks that we use is we give the medication and then we flush it with, instead of just water, we flush it with some formula that something that has some fat in it to be able to push that along through the tube. No, it has to have something that has fat, because it is a fat that you need, something like a protein-free formula that has some fat in it to be able to get it to move along. The challenge is that, as I said, it's great in the older population, but in the younger population, the volume is very small. You can be on 0.3 milliliters, several times a day. So administration of it is, again, tricky, because you need to make sure that all of it got into the patient, right? Children have the tendency to hiccup or have some degree of reflux, and so making sure that it all got in is also sometimes challenging in the younger group. In general, right now, if one of the therapies that we like to have, or one of the options that we like to have in some of our patients, is installation of a G-tube or gastrostomy tube. I understand that's not done too often here, but that when a child has a G-tube, oftentimes I will stick with the phenol butyrate option, which is, again, a powder that you can dissolve in water rather than switching to Ravicti, to the glycerol phenol butyrate. But only because it's a little bit more difficult to administer.
May I ask you?
Of course.
How do you set the dose and how do you control it?
That's a really good question. So a couple of things. One of them is I go by the prescribing information to some extent. I think every metabolic physician currently in practice thinks of phenol butyrate doses, dose in sodium phenol butyrate. So there is a conversion between glycerol phenol butyrate and sodium phenol butyrate that we all do in our head, and we back calculate that, right? So there the starting dose is 250 to 500 milligrams per kilogram. And so oftentimes I will figure out what that is and then go back, right? Which is a little bit awkward, but
Right.
I think none of us are familiar enough with this medication to know.
And of course, it depends on the extent of ammonia levels.
Absolutely, right? So you titrate.
Frequently,
You titrate to that dose, right? So in an infant who has a very severe hyperammonemia, I'm just going to start at the highest dose. There's not a lot of point starting at a lower dose. For patients with a milder disease and sort of the distal urecycle disorders, usually I'll start at another, the lower dose, right? And then I'll titrate accordingly, basically to what they need. But there is perhaps another better way to do this. And so one of the things that this company has done, again, maybe not the most expedient now that I'm being recorded, but this company has also done some research analysis based on the data that they have. So on the one hand, I think it's important because it puts important information out into the literature. On the other hand, it is a company doing research, so the research has to be taken to some degree with a grain of salt, right? So what they did, so this is really important to sort of maybe sort out your question, which is what is an appropriate dose for these patients? So there is a toxicity to phenol butyrate. The toxicity, the appearance of the toxicity is very much like a patient with high ammonia. There is an encephalopathy that results from this. So you have to be careful not to overdose. Now, when you give a medication enterally, of course, there is a very large first pass effect that sometimes it's difficult to measure exactly how much of the drug the patient is metabolizing. So what they did was they did a study, right? So on here they have the comparison of plasma PAA, which is phenylacetate, okay? On this side, and then over here is the ratio of plasma PA to plasma phenylacetylglutamine. So in other words, this is getting converted to phenylacetylglutamine. Right? I hope that makes sense. The phenylacetate is getting converted to phenylacetylglutamine. So what are we looking at here? Well, the idea is that if you, so at lower doses, right, virtually all of your phenylacetate is getting converted to phenylacetylglutamine. So you're not going to have zero of this in the blood, and all of it's going to get converted, right? At some point, you're going to overload the liver's capacity to metabolize the drug, right? And at that point, it starts to take off, okay? Right, the drug concentration in blood starts to take off, okay? Does that make sense? Right, so where does it take off? Well, they said somewhere between this range, right, is the safe range. Beyond that is where this starts to exponentially take off, right? So that you really, the target here as your phenylacetal acetate to PAGN ratio should be between 1 and 2.5, okay? So in cases where I feel that the patient, even on the highest prescribed dose, isn't well controlled, and I would like to push beyond that, I always check this ratio, right? Because this informs me as to how close am I to the patient's toxic level, okay? And so it might be in the future that we all do this. We all use this as our marker of therapeutic range. But right now, as far as I'm aware, not everybody is necessarily using this this range.
And it is tested on pre-transplant patients?
Yeah, of course. No, they're all pre-transplant patients. Post-transplant patients don't have any problem with ammonia, and therefore you don't need to check. You don't need to check this. They're not on ammonia scavengers anymore at that point. Does that make sense? Any other questions about this? All right. So there's another study again done using data from this company, but that looked at comparison between groups. If you had your fasting ammonia level was high or low, okay? And so really they divided this into several groups, right? They looked at the fasting ammonia level, they divided it into, this is, again, I'm sorry you can't read it, but it's less than half of the upper limit of normal, right? So the upper limit of normal is 35, right? Micromoles per liter. So I know that here they use micrograms per deciliter, is that correct? So I don't know what's the quickest conversion. I think it's like 0.6 to 1. So like I'm sorry, it's about double. I don't know, I think that's probably the best way, the quickest way to look at that is maybe 40% more, something like that, right? So, this range, below half of the upper limit of normal, right? This is one group. The other group is between 0.5 and 1, and the other one is above 1, right? So they looked at these groups in terms, they divided these groups in terms of what their baseline fasting ammonia was. And then they compared what their, so this is actually, I apologize, again, not very legible, but this is the mean ammonia level on this side, right? So the blue is the lowest group, is the less than 0.5. The red is between 0.5 and 1, and then this green here is obviously above 1. Okay, the average is above 1. And they looked at how many hyperammonemic episodes these groups had, right? Again, maybe intuitive, but those patients who had an ammonia level that was above the upper limit of normal were much more likely to have a hyperammonemic episode. They had a shorter time to the first time that they would have a hyperammonemic episode. Their relative risk for having one was 4.5 times the lowest group, right? And the rate at which they had them was 5 times the lowest group, okay? So, again, I'm not, maybe intuitive, I'm not sure, because at least in patients that we see in our clinic, we sometimes see patients who have an ammonia level that's slightly, you know, we would consider, I'm okay with an ammonia of 40, right? Like sometimes it happens, it's just slightly high, you say, oh, you know, maybe it's the blood draw, you know, exactly, you know, there are many other factors that are involved, and so I'm not, you know, I let that pass. But what this is suggesting is we should be really a lot more vigilant with what those levels are and trying to get those levels as low as possible, because, you know, those patients that have a low ammonia level do a lot better, right? The last thing I want to talk about, I feel like is a lot more topical now, is seizures in urea cycle disorders. It's not thought to be classically associated with these conditions, but I think that's partly because they are non-convulsive. The patient may be having electrographic seizures, but they're not actually having any convulsions that you can see, so you don't think about this. But it's certainly an important component. This is from a paper just sort of looking at the incidence of presenting symptom, or the percentage of patients with a specific presenting symptom, and seizures is in this type of box. That's this one at the top here, right? So not, apparently not many at first presentation, but certainly more the higher your ammonia is, right? So you should think about it in your encephalopathic patient with elevated ammonia. So I do want to show you this results from one patient whom we had with hyperammonemia. I'll just explain what happened. This is a girl with a urea cycle disorder who came in with a very elevated ammonia level here. I think it was above 800 if I'm not mistaken. And then as soon as we saw that patient, we dialyzed the patient. Okay, so this patient was started on dialysis and rapidly brought the ammonia level down with dialysis. The dialysis catheter clogged, right? So in other words, there was a clot or something that occurred within that catheter, and so was no longer running. And so very quickly afterwards, the ammonia spiked again because there was continued production of ammonia, right? And so then that had to get restarted and then came down again. Okay, and there's a little bit of rebound once more. So it took a little bit of time to get this patient under control. But I want to show you what the EEGs looked like for this patient. Okay, so this is when the patient kind of came in, which isn't, again, difficult to see perhaps, but not that bad, but it gets worse over time. So this is at 1, right? This is at that top point. This is at 2, right? So this is now grossly abnormal. Again, I don't know if you're familiar with looking at EEGs, but there's virtually no activity. There's basically this burst and then not a lot of activity thereafter. Okay? So that's here at 2. That means that the EEG findings lag behind the hyperammonemia, right? The hyperammonemia was highest here, but these electrographic changes had not occurred yet. Okay? Mm-hmm. You get to 3, it's getting better. Okay? Well, I mean, this still isn't great, but this is improved over what was before where you had no activity. Okay? Then you get to 4. Okay, so the ammonia spikes again. Once again, you get this very burst suppression type picture. Okay? And then at 5, again, your ammonia is still descending, but the EEG picture lags behind what you can see in terms of the ammonia, okay? And then as you go along, then you see sort of this activity back again, and the patient ends up, you know, one of the difficulties here, one of the challenges is that you know, as the ammonia comes down and sort of the neurons start to activate again, then they're hyperactive and you can have a seizure, you can have a frank seizure at that point too. So it's again something to watch out for as the patient recovers, okay? So, and what we're starting to find is we're doing studies, both animal studies as well as human studies as well, to look at this and some of the features of electrographic changes you can see in patients. The reason why obviously is these are the types of things that you would want to suppress or prevent in this patient group. But one of the things, this is from an older publication, but that showed very similar results to what we have, which is that these patients during the intense hyperammonemia can have what's called a burst suppression pattern on EEG, right? So you have a lot of activity and then nothing and then a period of other activity. And that essentially that the interburst interval, right, the length of the burst and the interburst interval was correlated with the degree of hyperammonemia, right? So the worse the hyperammonemia, the longer it was between bursts and longer the bursts were, right? And so this is, again, another marker of the effect that the ammonia has on the brain in these patients.
Is the ammonia or the glutamine?
So you're right. So that's actually a really good question. So it's probably the glutamine, right? So so when ammonia gets into the central nervous system, there's so much glutamine synthase that it's almost instantaneously converted into glutamine, right? So that glutamine has many secondary effects. So a lot of the studies that have looked at what is the effect of ammonia toxicity on the brain, it's extraordinarily complex. But essentially, there are glutamate transporters that are affected within the brain, right? So sorry, I'm sorry. I said glutamate. I really meant glutamate. Okay, so those two obviously within the central nervous system can cause a lot of effects. But the idea here being that there are multiple glutamate transporters within the brain, right? There's the NMDA receptors. That there's another one called AMPA receptors that basically are channels for glutamate, which is with a neurotransmitter. There are other receptors within the cell itself, what are called metabotropic receptors for glutamate. And apparently they also have disparate effects on other neurons that use other neurotransmitters like acetylcholine and serotonin. So the sort of the CNS effects, especially long term, kind of affect a little bit of everything, which is really surprising. But it makes it very difficult to kind of pinpoint what are the specific effects of hyperammonemia on the brain, because it affects a lot of different things.
And would you put on antiepileptic drugs?
I think so. I think during this period, I think this means that we should think about this more often, because this is not something that in a non-convulsive patient you wouldn't think about doing.
Maybe
so I think we should consider doing that more often.
Have an EEG.
Yeah, and so this is now our protocol, that every patient with acute hyperammonemia gets a video EEG, because you don't want to miss this type of thing. Certainly, I mean, we don't have any prospective studies to show this, but I would think that seizures is not good, right? They're not going to, they certainly will have a detrimental effect in this group. So we are starting to do that more routinely now.
But if you don't have an EEG, you don't put it like as prophylactic.
Right, well, you wouldn't know, right? I mean, I don't know. I've never been in that. I've never had that situation, right? But there've been no recent. But you're right. I mean, like historically, we never checked, and so we never put them on these medications unless we saw a frank seizure, right? But I think now we're seeing the electrographic seizures, and so these patients are getting treated as a result.
I mean, we don't have EEG 24 hours a day.
Okay.
At every hospital.
I see. Okay. Well, so I think it would be worth considering for a few reasons. One of them is obviously to prevent this. There's some other suggestion that you can also reduce the metabolic load of the brain, right? So again, I don't think that's proven, but the idea is that when the brain seizes, that it uses a lot more energy than if it didn't, right? And so that if you were to suppress that activity, that you would be able to reduce the energy requirements of the brain. Does that make sense? So I think there is some validity to sedating the patient, right? Even without seeing any electrographic changes. The flip side, though, is it does kind of blunt your neurological exam, right? If the patient is sedated with medications, then the exam is worthless at that point, right? It's not very useful at that point.
How big usually takes between the signal on the EEG and the risk of the seizure?
Yeah, so that's a good question. I think it's really variable dependent on the patient, but the idea is that during recovery you should.
It's a matter of minutes.
Yeah. No. I think it's the matter of hours. You're looking at some hours between that, and yeah.
And there is no marker before the hyperammonemia that you may control, or it's just like you
No, that's a good question. I don't know. So there may be. We have not found one yet that would suggest
Then,
right.
Always.
Yeah. We're again something that's still being worked on and sort of sorting out what are the best ways to kind of prevent this from happening. And maybe the answer is that at that stage you preload the patient with some kind of anti-epileptic. I'm not sure. Again, this is still unpublished data, so I don't. So just so you're aware, this is not clear yet, right? So this is. I bring this to your attention because I think it's worth thinking about more often in the patient population that you take care of, and then also that this is gonna, I think, be sort of the forefront of some of the work that our group as well as other groups are gonna do in terms of neuroprotection for patients in neuropsychiatric disorders, right? Effectively, they're long-term, the two main issues with neuropsychiatric disorders are going to be correction of the genetic defect and neuroprotection, right? That's what this comes down to, and so you will see that there are advances in these two major areas.
Nico, have you? I'm jumping behind.
Sure.
Have you tried glycerol phenol butyrate for an acute hyperammonemic crisis? Have you ever used it or no?
No, I have not. And the reason why is because, okay, let's go back to that. So these steps take time. So this process can be fairly slow. In fact, I would say that it is reported by the company, if you will. I don't know how else to put that. It's reported by the company that you get better control over the long term. In other words, over the course of a day, less peaks and troughs of phenol butyrate by giving glycerol phenol butyrate. Right? It's a fat. It takes longer to break down. Right? Phenylbutyric acid takes about 30 minutes to an hour to convert to phenylacetate. Right? So these steps take a little bit more time. Right? So acutely, they will take longer to work. So preferably, if you have it, I would give phenylbutyric acid instead, right? Phenylbutyrate. Or even better, if you have infused medications, whether it's a sodium benzoate or phenylacetate, that would be even quicker acting than any of these other options because they're given orally. Because it takes some time for it to get the gut and then, et cetera. So it takes longer. Other questions? Okay. So really that's again, I leave you with sort of the forefront of what our work is currently. I'm happy to take any questions you guys have about neuropsychiatric disorders in general or anything else that you might have on your mind. Can't be nothing. Means I talk too fast. Yes.
Sometimes they use sodium benzoate plus.
Yes. Right. So no, but we should. I think we should. Carlos, what you describe is maybe more of a regulatory thing than an actual medicine thing. Phenol Butyrate is an approved drug, so it can be prescribed, and there are no difficulties getting it covered through insurance. Sodium benzoate really isn't. It doesn't have an indication. There's no way to prescribe it in a fashion that it will get covered through insurance companies, which is absurd because, as you know, sodium benzoate is very inexpensive, right? You can be obtained very cheaply, and phenol butyrate, because it is made by a company, even though there's a generic now, is extraordinarily expensive. But the expensive one is the one covered by insurance, and the cheap one isn't. Again, hello to the camera for my politically inexpedient statements.
So, for an acute crisis,
Yes.
what's the superiority or edge of phenyl acetate is the speed, or is there any other?
Strictly the speed. That's it. It gets to the patient, it gets to the liver quicker. There's no other, than phenol butyrate or glycerol phenol butyrate, it's only the speed, as far as I'm aware. I don't think there's any other advantage.
And is there any advantage to combining sodium benzoate and phenyl butyrate, or giving just? Is there any, why
Sure.
do they mix this?
Yeah, so we have an approved drug in the United States. It's a combination intravenous therapy for both of those, phenyl acetate and and sodium benzoate, sodium phenyl acetate, sodium benzoate, right? That's infused, combined, right? And so that is the therapy of choice in a patient who has, in crisis, very elevated hyperammonemia. So that's what we will give as our drug of preference. We'll often give a bolus of the drug followed by the continuous infusion. There are some side effects, probably that you've seen with sodium benzoate alone, that you can get if the fluid extravasates. It can result in a burn. So usually we prefer giving it through a central line, but if there's no access, we do give it peripherally. As mentioned, in some of the disorders, arginine can be an effective agent to bring down ammonia levels. That we almost always give centrally. That almost certainly will extravasate and cause burns, so we never give that peripherally. But that's usually our treatment of choice in a patient with hyperammonemia that we think can be controlled with medication alone. Right? If it becomes too high or the patient's encephalopathic, then that's dialysis.
Would you mind commenting a little bit about gene therapy?
Sure. Okay, so we had a very brief discussion before. I don't know if you're familiar with sort of the historical aspects of gene therapy in OTC. So as you might know, 20 years ago, there was a trial that was done using a vector called adenovirus. Adenovirus is big, right? So you can put a lot in the virus, right? Basically, you can remove its DNA and insert a cartridge. Basically, your corrected OTC gene that you can give to patients, and that hopefully that it would correct. It would insert that gene into hepatocytes and correct your the genetic defect. Well, it's not really correct the genetic defect, but it provides the correct enzyme, if you will. It provides a functional enzyme. So when they did that trial 20 years ago, they did a dose escalation, right? And the very last patient who got that died because of the immune reaction against the adenovirus. So that halted gene therapy in urocycle disorders, and for the most part in the US for almost 20 years, kind of 10, 20 years. So there are new trials now that are looking at other forms of gene therapy. One of the preferred vectors now is something called AAV8. So it's adeno-associated virus. It's a little unfortunate that it has that name. It has nothing to do with adenovirus at all, other than the fact that when they looked presumably electron microscopically, that they saw that around these adenoviridae that there were these smaller viruses that are adenoviruses that have no, as far as we were, no pathogenic potential. Right, but it is the downside is it's much smaller, right? So you have to be a little bit more creative in how you replace the the gene, right, that you put in there. And so there are now new trials that are looking at using AAV8. So there are multiple different types of AAV. AAV8 tends to be the one, or is the one that has been shown to have more hepatic specificity. So you can get the virus to where you want it to go and not to other places where you don't want it to go. There's an upcoming trial that will look at the use of AAV8 in humans. So in animals, right, in mice, perfectly corrects the hyperammonemia in mice with OTC, right? So that's very easy. And now they're looking at human trials for this, right? And so these trials will essentially be again, in the same fashion, a dose escalation. But the thought is that, again, it doesn't have any human pathogenic potential. So theoretically, should be much safer in humans.
That will only be alternative treatment to liver transplant, or?
Well, so it's an experimental therapy, right? So nobody know. I mean, it may not work at all. I don't know. So it remains to be seen whether this trial is successful in showing that it works. But
in case it worked, it would be alternative therapy to liver transplant or not.
Again, maybe. Again, I don't know if it works and how long it works for, right? So if it works, but let's say, so the trick here is that the AAV and the corrected OTC gene has to make its way to enough hepatic stem cells. That's really critical. So for instance, I don't know if you're familiar, a few years ago there were some therapies using hepatocyte transplant, right? So what they would do is they would take liver, right? They would get the cell, basically the hepatocyte, and inject that into the portal vein with the hopes that those hepatocytes would seed into the liver, which they do, of course, but then it's just a hepatocyte. So over time, presumably there's loss of those hepatocytes, and the liver will continue to replicate and produce deficient cells, right? So that is, I think, is the reason that's not sustainable as a therapy. So for this to work, it has to, one, get into those cells. And the challenge here is, unlike some other disorders, there is no survival advantage to the cells that have that corrected gene, right? There isn't any survival, so they're not going to proliferate any faster within the liver. Again, it works great in mice. So the hope is that will work in humans as well, but it remains to be seen. And it could, the mice don't live nearly as long as humans, so it's possible that, 10 years down the line, the therapy doesn't work anymore, maybe, right? I don't know. In which case, what are you going to do? If this is a therapy that works, potentially giving it again won't work because the body may mount an immune response to it. We don't know this yet. So then they will still need a liver transplant, maybe, right? So again, a lot of unknown questions, questions to which we don't know the answers to yet. But hopefully, at least through some of this trial, we will sort out. I hope that addressed most of that. I don't know if you wanted more discussion. So the next step beyond that is Crispr Technology, right? So the idea is that you have you correct in situ the defect, right? So this is, again, works great in mice. I don't know when the human trials of that is going to be, but that certainly, as far as I'm aware, no human trials yet of any of those. Other questions? Things of interest? Really? That's it? Okay, well, with that, thank you so much. I certainly really appreciate you inviting me here to talk with all of you. I want to say that I've only spent a couple of days in Argentina and Buenos Aires so far, but it's been really beautiful. It's been a fantastic time, and I've been really thrilled to be here. So I really appreciate the invitation to come speak with all of you. Just thank you so much. And again, this is kind of our hospital here. very kind of, I think it was built in the 80s or something like that. It kind of it looks like the Death Star a little bit, kind of thing. And of course, I show you the Washington Monument which you also have one in our Capitol building as well.
Careful, because it does explode, no? At the end, or no?
Yeah, at the end of Star Wars it does. Hopefully our hospital will be, hopefully our hospital will be.
Okay,
Thank you so much.